Hello everybody, I'm Dr. James Hall. I am a nephrologist. I've been practicing about 20 years. And this video, we're going to talk about severe hypertension and hypokalemia. We get referred a lot of patients to our nephrology clinic when they have hypertension and hypokalemia. And this seems to be a source of confusion and complexity for our primary care providers. So we're going to give you some of our top 3 things that we see when patients come in with hypertension and low potassium. The first thing that I look for in our clinic is hyperaldosteronism. That's basically where you have an adrenal tumor that's secreting too much aldosterone, and that's causing your blood pressure to be high. If you'll notice right here, I don't know if you guys can see that, but this is your kidney. But if this little gland here is the adrenal gland, it's right next to the kidney. And so this gland can have some adenomas that will secrete too much aldosterone that causes you to lose potassium and conserve sodium, and that raises your blood pressure. Now, this hyperaldosteronism is under-recognized and underdiagnosed in the medical world. So that's one of my knee-jerk reflexes to check when a patient comes in with hypertension and low potassium. The other thing, and just a quick tidbit, the way we screen it is we check a renin and aldosterone level. So that's something you can do in clinic if you want to, or you can just refer to nephrology and let them do it. The second thing that we see is renal artery stenosis. A patient comes in, their blood pressure was normal 10 years ago, and you'll notice now it's kind of going up, severely elevated. They're on 2 or 3 blood pressure medications, and you cannot get it down. And their potassium is low. That's another indicator that this patient probably has renal artery stenosis. Typically what I see in our clinic, we'll see a patient who's a smoker, or a patient who has atherosclerosis, coronary artery disease, or some other type of arterial plaques that's causing basically those renal arteries to be small and to be stenotic. And that's what causes the hypertension. That's what also causes the kaliuresis, or the potassium wasting in that patient. Typically what we do to look for this is we'll get a CT angiogram of the bilateral renal arteries, or we'll just get a MRA, a magnetic resonance angiogram of the bilateral renal arteries if the patient's creatinine is elevated, and that will tell us the patient has renal artery stenosis. Patients like this, we don't want to put them on an ACE inhibitor or ARB, because that can further potentiate that stenosis on that kidney, that diseased artery. So this is another indicator for nephrology referral. Little syndrome. This is the third thing that I look for in our clinic when a patient comes in with severe hypertension and hypokalemia. Little syndrome is a mutation of the sodium channel in your tubules in your kidney. And basically this particular hormone is hyperactive, and it conserves sodium, and it causes excess potassium wasting. We see it a lot in African Americans. We also check for it by doing a genetic analysis. So it's not like necessarily a lab that you get routinely, but if you see a patient with hypertension that started when they were young, 18, 19 years old, and their potassium is somewhat low, or you put them on a hydrochlorothiazide or diuretic and their potassium drops significantly. Sometimes patients can be hypokalemic, or they can be relatively hypokalemic, and you put them on a diuretic and it can unmask that. So the patient potassium may be normal, 3.6, 3.5, at the lower end of normal. So nobody picks up on the fact that this patient could have quote unquote hypokalemia. But when you put them on a diuretic, it unmasks their underlying disease, and you'll actually see the potassium drop. Well, yes, the diuretic contributed to it, but the average patient should be able to handle a low dose diuretic without a drop in their potassium level. So this is another thing that we look for in patients who come into our clinic with hypertension and hypokalemia. So these are the top 3 things that I see in our clinic when patients come in and their blood pressure is out of control. They're on 3 or 4 blood pressure medications, and their primary doctor, you, cannot get their blood pressure under control. So when you see that, think outside the box. Think, what could we be doing that's causing this, or what could we be missing in the patient's diagnostic workup that may be causing the hypokalemia, the hypertension. And always, if you can, try to refer to nephrology if your patient's blood pressure is not under control. If their potassium is not under control, referring to nephrology is always a great option so that your patient can get the best possible care. Check us out below. You can check our free webinar out, or you can go online, enroll in our course. This course is basically an online course that teaches you all the things that we do in nephrology, and it gives you all the clinical management guidelines that you'll need in primary care. Thank you for tuning in. Check us out on the next video. Bye.